I'm delighted that you're here, and I'm Kenneth Polonsky, Dean of the Biological Sciences and Pritzker School of Medicine. This next panel is going to deal with medical and public health initiatives. We're delighted that we have three experts to be able to lead the discussion. I'll introduce them in a moment. I think what you will see is the theme, as the sort of organizing theme, is that this epidemic of crime and violence is really a public health issue. It has certainly enormous public health implications. We need to think of it as a public health problem. And to provide insights into that, we have, as I said, three outstanding people. The first speaker is Dr. Jennifer, is that better? Is Dr. Jennifer Cohn. She's a assistant professor in the Department of Surgery at the University of Chicago. To her left is Dr. Selwyn Rogers, who's a professor in the Department of Surgery and head of our Adult Trauma Center. And then Dr. Joseph Sakran, who we're delighted has joined us from Johns Hopkins Medicine. He is the Director of Emergency General Surgery and Assistant Professor of Surgery at Johns Hopkins. So Jennifer, why don't you start?
I'm Jen Cohn, and I'm one of the trauma surgeons here at the University of Chicago. And today I'm going to be talking to you from a medical perspective about why I believe we're at a tipping point for gun violence in America. So we're going to take a step back from talking about gun violence for a second, and we're going to look at car accidents. Between 1900 and the 1950s, there were more and more cars introduced into American society. And with that, of course, there were more car accident deaths. So, of course, cars were designed, right, to get us from point A to point B. They were designed to get people places quickly and in style. They weren't designed with safety in mind. And when more cars were on the road, there were more motor vehicle collisions. And again, with that, more deaths. Now, members of the public and members of the media began to recognize the inherent danger that cars pose to the American public. And physicians at the same time were recognizing this, right? They were treating patients of car accidents in their ERs and ORs, and they began to do research on this. So these physicians and members of the public health community were trying to figure out the burden of injury and how to make cars safer for the American public. This is one article that I found especially interesting because it parallels a lot with gun violence. It's titled "The Doctor and the Automobile Accident," and I'll read it just briefly. Last year, there were about 38,000 deaths from automobile accidents and 2 million injuries from the same cause. Approximately 100,000 of the people injured were totally disabled. Surgeons and physicians were probably worked on many of the injured, but the dead were a total loss to their family, friends, and doctors. Many of the disabled have become a burden to themselves, to their families, or to society. At least one accident insurance company has made the dire prediction that someone in every family or group of friends will have a serious auto accident during the next year. And apparently doctors and their families are not immune. Each doctor, therefore, should have a personal interest in this matter. Now, these public health experts and physicians were really addressing this matter from a public health perspective. They were trying to identify they were trying to approach it from a harm reduction perspective. Nobody wanted to take away cars from the American public. They were just trying to figure out a way to make cars safer. And all of this research culminated in the National Traffic and Motor Vehicle Safety Act, which President Johnson signed into law in 1966. And what this law did was it essentially ensured safety standards for cars, roads, and drivers. And because of this, private companies began to do research in order to make their products safer. They were essentially competing for the safest product on the market. And as a result of the research that was being done both in private industry and on a medical side, we had policy advancement, things like car safety seats, helmets, airbags, seatbelt laws, minimum drinking ages, and standardized driving exams. All were put into place to make the American public safer when they were in a car. And because of these measures, these vehicle safety technologies, it's been estimated that since 1960, over 613,000 lives have been saved by these public health advancements. Now, This is the slide that I initially showed you, and I believe that the research that was done in the National Traffic and Motor Vehicle Safety Act really was the tipping point for motor vehicle fatality in America. So you're sitting there saying, so what? What does this have to do with gun violence? You may even be the one person in the audience that doesn't actually believe that gun violence is a problem. I'm here to try and convince you otherwise. So if we look at what kind of patients our trauma centers take in nationally, about 4% of trauma admissions are from gun violence. But if we change the way that we look at the data and say what is actually the burden of death from each of these traumatic mechanisms, the playing field is leveled. The same amount of people die from motor vehicle accidents, from firearms, and from falls. Even though only 4% of trauma admissions are from gun violence, an equal amount of people are dying from gun violence. Guns are just inherently more lethal and deadly than other kinds of trauma. So what are the raw numbers? Over 39,000 people in the United States die each year from gun violence. That means 300 people are being shot every day, and 100 people are dying every day from gun violence. The US has a gun homicide rate 10 to 25 times higher than that of other high-income countries. If you look at the raw data, the United States actually ranks only 26th in the world for its gun murder rate. But if you change the way that you look at the data and rank the countries in terms of how developed they are, how much infrastructure do they have, the United States has 4 times the gun murder rate than its closest competitor. These numbers are astounding. The United States has had more deaths from gun violence in America from 1968 to the present day than the casualties of all of the US wars combined. From the Revolutionary War all the way through the Iraqi War, there still have been more deaths from gun violence in the last 50 years. As I mentioned before, over 39,000 people died last year from gun violence. That includes 15,000 homicides and 24,000 suicides. And these numbers don't include the injured, which includes 29,000 people. And if you look at these numbers, over 1,000 children and teenagers died last year because of gun violence. In the last 2 months alone, 4,500 people in the United States have been shot, and 6,800 people have died because of guns. In the last 2 months, there have been 47 mass shootings in the United States, where 4 or more people were shot. These numbers are astounding. This is so commonplace in America, it's not even making the national news anymore. Meanwhile, in Chicago, somebody is shot every 3 hours and somebody is murdered every 17 hours. In 2019, 461 people were shot and killed, and 2,300 people were shot and wounded. Now, it's very easy, right, to talk about these numbers in a sterile way at the University of Chicago Law School on a PowerPoint presentation, but these numbers do not reflect the totality of the human toll of gun violence. This is what it looks like when somebody bleeds out and dies from a gunshot wound. And these pictures are hard to look at, but they are not isolated events. This is what we're dealing with on a near daily basis at the University of Chicago. This is the consultation room where I talk to mothers, fathers, and children and have to tell them that their loved one has died from gun violence. Guns are destroying families, they are destroying communities, and they are destroying the fabric of our society. It's been estimated that the annual cost of trauma is more than double that of heart disease, diabetes, and cancer. Specifically, the societal cost of firearm injury is $174 billion. That's more than we spend on education in the United States. That's more than we spend on transportation. That's more than we spend on homeland security in the United States. $10 billion of that is in direct costs, like police wages, hospital fees, and court fees. $50 billion of that is in indirect costs, like lost wages, and over $100 billion is in lost quality of life. We know that gun violence disproportionately affects younger people, and it's essentially killing an entire generation. The large white circle here represents the total NIH funding in 2015. The teeny tiny orange circle that you see represents the trauma-related funding, which represents only 0.02% of the NIH budget. We know that gun violence affects so many people. It is so deadly and so costly to take care of. But why is there no money being devoted to gun violence research? In part, this is because of the Dickey Amendment, which was passed in 1996. Now, the Dickey Amendment arose out of a battle between gun control researchers and gun right activists, and it really was billed in Congress as a compromise. What it actually said was that the CDC could do research, but they couldn't use any of the funds that they received to promote or advocate for gun control legislation, i.e. they couldn't do any lobbying. Now, the CDC was not in the business of doing any lobbying. And in effect, what this amendment did was that it imposed fear over the entire CDC to completely avoid doing gun violence research. And in the years that followed, $2.6 million was stripped from the CDC that was previously designated to gun violence research. Okay? It made the distribution and collection of data difficult, and no grants were awarded to study gun violence research. In 2017, Stark and Shaw studied the funding and publication of research on gun violence and other leading causes of death. On the top graph, you'll see funding, and on the bottom graph, you'll see publications. And what you'll see is a nice linear trajectory with diseases like cancer and heart disease that affect a lot of people and have a high mortality rate, receiving a commensurate amount of funding and having a commensurate amount of publications. What I want to draw your attention to, if this will work, it won't, but is the orange dot, which represents gun violence, and it falls far below the curve. Gun violence received 1.6 amount of the funding predicted for how deadly it was, and had only 4.5% of the publications predicted for how deadly it was. This essentially combines those last two graphs. What you can see is that sepsis, which had essentially an equivalent death rate in the United States as gun violence did, had 99.3% more funding than gun violence did. Gun violence had the second lowest amount of funding and had the lowest publication rate of all the diseases that they studied. Do we even know if gun control will actually prevent violence? The Task Force on Community Preventive Services actually looked at this a couple of years ago. And what they did was they evaluated all of the laws in various states and the measures and interventions that are in place. And what they found for every single measure was that there was insufficient evidence to determine if it was effective or not. We just do not have enough research to know if what we're doing is effective. We need to do more research onto this disease. In 2012, Jay Dickey, who was the senator who had initially sponsored the Dickey Amendment, had actually reversed his viewpoint, and he started calling out for more gun violence research to be done. So how are we going to stop gun violence? I can continue to fix holes in bodies, or we can try and fix the root of the problem by doing fundamental research. Now, the tides have really turned in the last several years, and my colleagues are going to talk about some of the research policy and advocacy work that physicians and public health experts are doing to prevent gun violence. But what we really want to do is stop this endless cycle where there's a shooting and thoughts and prayers are espoused on social media and then nothing happens. And this cycle continues day in and day out until there's another gunshot victim. And in a place like Chicago, that can be 1 hour later. As physicians, we've long lent our voices to concerns of public health. We're literally the keepers of the public's health, and we have unique access to our patient population. I believe as physicians, we have a moral responsibility to engage in issues that produce health for our patients and to advocate for both personal, individual, and public health. As a trauma surgeon here at the University of Chicago, I see interpersonal violence as one of our core issues, and guns make that violence much more morbid and lethal. The U.S. has found ways to reduce the risk of death from car accidents by doing fundamental public health research. I believe that we can be at a similar tipping point for gun violence in America if we apply the same rigorous public health research policy to gun violence. And I believe optimistically that policy will follow the evidence. Thank you.
Well, I want to thank everyone for being here and attending this very important symposium. I look forward to the questions at the end, probably the most dynamic part of our time together today. It's a weekend, right? It's Friday. And I think everyone here is looking forward to the weekend. But our weekends on the trauma service look this way. So last weekend, which is very representative, or likely of this weekend, we had 3 traumatic arrests. We had a 25-year-old man who was suffered gunshot wounds to his chest and unfortunately passed away. A 30-year-old man who had multiple gunshot wounds and also passed away. And a 20-year-old female with 2 gunshot wounds and passed away. Concurrent over that weekend was a 31-year-old man who was shot in the left thigh, who survived, and a 26-year-old man who was shot in the pelvis, underwent emergency surgery and survived. This is all too common scenario, weekend after weekend, day after day. On violence, David Satcher said, if it's not a health problem, then why are all these people dying from it? The challenge is, if we're going to move forward in terms of finding solutions to gun violence, we need a threefold approach. We need to look at tertiary, secondary, and primary prevention efforts to address violence, gun violence specifically. Tertiary prevention refers to harm reduction, basically access to trauma care. Secondary prevention refers to things like our violence recovery programs that Ben Gibson discussed in the last program. We have a few members of our violence prevention team in the audience. And primary prevention addresses things like gun safety, improving social conditions, and improving mental health, and reducing substance use and abuse that leads to higher rates of suicide and other aspects related to primary prevention. So let me start with going over tertiary prevention, harm reduction. One of the big reasons why the University of Chicago Medicine became a trauma center had to do with the relative trauma desert on the south side of Chicago. You can see the University of Chicago in yellow there, large amount of shootings on the south side, sparing most of Hyde Park. But since 1991, there was no adult trauma hospital on the south side. Lack of access to adult trauma care was highly controversial, and community advocacy was a key proponent to promote gun violence, to promote adult trauma services. We opened a trauma center on May 1st of last year, and pretty right away we became one of the busiest trauma centers in the city of Chicago. One of the important distinctions, though, trauma centers are basically centers where people go who are traumatically injured, be it from blunt, meaning car accidents, falls, or penetrating trauma, stab wounds, and gunshot wounds. Month to month, our services at the University of Chicago has about 40% of our trauma due to penetrating trauma, with the vast majority of those traumas being gun violence. And the challenge of addressing that is related to the fact that oftentimes, once people are shot in certain areas, no matter how assiduous you are in providing care, a patient will die. What's the important role of secondary prevention efforts? This basically has to do with trying to prevent retaliatory violence in the form of violence interruption and violence recovery programs. These secondary prevention efforts reflect the opportunity to intervene in a teachable moment for people who have been the victims of violence to help prevent retaliatory violence or being re-injured. This is a graph from the University of Maryland Shock Trauma Center over a 10-year period, where it looked at people who have been shot once and only once versus people who have been shot more than once. The upper line is the people who have been shot once and only once versus the dotted line showing a higher mortality for those who have been shot more than once. A lot of that has to do with recurrent injury that leads to death, but also being disconnected from social services that impact upon one's overall health. Hospital-based violence recovery programs have been in existence for about a decade now. They're basically multidisciplinary approaches to offering support, ongoing case management, and advocacy for victims of violence to prevent rehospitalization and re-victimization. These recovery efforts are largely tailored to provide specific goals related to immediate safety, housing, vocational training, mental health services, and social support to prevent re-injury. At the University of Chicago, our violence recovery program has a number of wraparound services that provide direct services to patients and their families, a degree of continuity, connection to community-based services, and in trying to attempt to minimize risk of retaliatory intentional violence. This is a slide depicting just some of our data from the violence recovery program over the past year. Most of our patients are between the ages of 22 and 30 who engage in the violence recovery program. Over 63% are victims of gun violence, with another 18% being assaults and 18% being stab wounds. And the vast majority, as you can see, are related to gun violence. We have a number of community-level partnerships to impact retaliatory violence as well as to impact upon the social determinants of health. Our street outreach program includes programs like Institute for Nonviolent Chicago, Activist, which is formerly Cure Violence, Chicago CRED, and a number of other programs around the city that are trying to make an impact in the violence prevention space. Social determinants are largely around the issue of providing mental health and other behavioral health services for victims who are both survivors of violence as well as their families. Finally, primary prevention reflects the larger efforts to try to create a more equitable and just society. Primary prevention has to do with the fact that we often focus on the dramatic event in the middle of this box, but don't talk about the built environment and lived experiences that people have that lead to some people being more at risk of violence than others. The built environment basically shapes our health. As we know, our zip code has a large impact upon how long we're expected to live and the quality of our life. Where we work, where we live, where we play, our infrastructure, our schools, and environments that you feel unsafe, you're more likely to be injured. This is a complex slide that basically shows that there's a myriad of factors, with guns being the bottom line with respect to the risk of injury. We often focus on the event of the gunshot wound shooting, but don't discuss the individual decision making or the upstream factors of racism, segregation, educational disparities, and economic outlook that puts some individuals, especially those on the south and west sides of the city of Chicago, more at risk. If you look throughout the city of Chicago, the areas of violence are most often the most disparate and the most economically deprived. If you look at housing elevated blood levels, for example, south and west sides of the city of Chicago, higher rates of lack of graduation from high school, south and west sides, and similarly the highest rates of unemployment in communities of color on the south and west sides of the city. We just had a conference yesterday, a combination of the collaboration between University of Chicago Medicine and Christ Medical Center for a program called Southline Rise, Resilience Initiative to Strengthen and Empower. Basically, it's stems out from an effort by Senator Durbin to get hospitals more engaged with violence prevention efforts throughout the city. And that effort basically led us to have a number of programs related to violence prevention, primary violence prevention, by having rapid cycle grants for a number of organizations that are doing grassroots work for violence prevention in the community. Here's just a list of some of those organizations. But solutions for gun violence, as we'll talk about more, requires engagement, partnerships, more data, more research, but education, advocacy, and greater communication. We got to change the narrative around gun violence, because one of the things I think that unfortunately has happened is we have too much focus on the mass shootings, but not on the daily shootings. Too much focus on the gun itself and not the impact of the gun upon the lives of people. And by changing the narrative, we may have more ability to have an impact. So I look forward to our conversation and discussion.
All right, well, good afternoon. My name is Joe Sakran, trauma surgeon from Hopkins, and it is fantastic to be here. I want to thank the panel and, of course, Dean Polonsky for moderating, but also Dean Miles and Carolyn for helping get me here and organize this. This is, I think, as you'll come to see, in my perspective, one of the most important public health problems that we are facing in this nation. And I can't really talk about this issue without telling you my own story. The son of immigrant parents, that came here to this country in search of those hopes and dreams that so many of us strive for. And I was born just outside our nation's capital at Fairfax Hospital, which is in Falls Church, Virginia. And at the age of 17, my life really changed after I was nearly killed when shot in the throat with a .38 caliber bullet. And at that age, I think most of us probably have no idea what we want to do for the rest of our lives, right? Most of us don't realize the fact that we're mortal. And that really, for me, was a turning point. And so I start this conversation recognizing the two individuals, Bob Ahmed, my trauma surgeon, and Dee Mukherjee, my vascular surgeon, that really, along with their teams, provided me with this second chance. And I love this Brad Paisley song, which says, at 17, it's hard to see past Friday night. And I think that was very much where I was at. And I remember very vividly when I was home from the hospital after a couple months, and I was standing in the bathroom, I was looking at the mirror, and I still had a tracheostomy tube. And what I didn't realize is my father was standing in the corner. And I think he saw the look of devastation in my eyes. And he walked in and he said, listen, he said, you have two options, Joe. I know what happened to you was horrible, but either you can feel sorry for yourself or you can take this horrible incident and try to impact the lives of other people. And that for me was really, I think, the turning point of the rest of my career. And sometimes I look back at it and I say, man, the worst day of my life was also the most impactful. And so, you know, I wouldn't be here without these folks you see in the picture who really have been there through the good times and the bad, and I'm just so grateful for them. And of course, you know, when I initially got into this, I was like, okay, I was inspired to go into medicine, to become a trauma surgeon. I actually went back and trained at the hospital where I was a victim and patient at. And that was pretty cool because I got to train with the surgeons that saved my life, and that's a whole nother conversation. And then I went to Penn where I really, I think, began to understand, you know, the care of the critically injured patient. But I kept asking myself, how do we look beyond simply the operating room, beyond the trauma center, and try to prevent these injuries from actually happening? Because by the time we are seeing them, that's really the end game. And that's really some of the lessons I learned while at Hopkins, where I love the motto. It says, protecting health, saving lives, millions at a time. And I think that this reflects both the opportunity and the responsibility that we have in thinking about this as a population and public health problem. And it's also what took me to the Kennedy School, where I really started to understand the importance of public policy. I think all of us can probably appreciate that we would not be here without the people in our lives. And so there's so many mentors that I can't even begin to name that have really impacted me tremendously. I just want to say, before I get into some of the meat of this, that my views don't represent Robert Wood Johnson or the National Academy of Medicine or the United States government. So I'm working in the Senate. That's the reason for the last piece. Everyone's like, well, what is he talking about? I'm on sabbatical. During college, I was a firefighter for about 4 years. And I put this up here because I know probably some of you in the audience are like, oh, look, there's Joe as he takes a photo op and the building behind him is burning down. Well, I can guarantee you that wasn't the case. But what was happening here was this was a training exercise. And so we had come out of the building as the next team went back in. So the point, though, here is that perception is not always reality. And as we talk about these emotionally charged issues, I think the way we talk about them and how we approach them, it's so important to hold our judgment. I mean, how many of you in here have been in the meeting and someone says something that you don't agree with, what happens? All of a sudden, you stop listening to them. You're like, well, that person's wrong. And you probably know that 90% of communication is nonverbal. And so they get that feedback and they stop listening to you. And you know what? The interaction breaks down not just for that one moment, but for future interactions, because you remember that's the person that said something I didn't really agree with. So I think it's just important to keep this in the back of our mind. I know that Dr. Cohn did a great job of going through the epidemiology. I just want to mention one really important thing. Someone once said to me, well, you know, Joe, the rate per 100,000 is not that much overall. And they may be correct, 4.5 per 100,000. But data depends on how you look at it. And so as you look at the homicide rate across this country by age and by gender, what you'll find is trauma is a disease of young people. And when you look at young white males, you can see how that rate jumps up. What happens when you incorporate race? This is just black males overall. What about young black males? So the point here is the disparity that exists as it relates to age, right, gender and race is critical. My colleague, Dr. Campbell from the University of California, San Francisco, had been taking care of patients after the YouTube shooting. And there were a couple patients that had come in, and he came out, surprisingly, and saw all this media. And he said to them, where were you yesterday when 4 African-American kids were brought in? And I think this goes along the discussion that we've been having today, which is the mass shootings get a lot of the media attention, but the reality is that this is happening every day. And frankly, young brown and black men are being slaughtered on our streets in cities like Baltimore, Philadelphia, and here in Chicago. And we're not telling those stories. So we have the responsibility to tell those stories. This is a complex disease, and we have to look at it as a, I think, biopsychosocial disease, and we can get into that in the question and answer session. I'm not going to get into too much of the research, except I'll just mention the $2.6 million that you heard Dr. Cohn talk about. That's not a random number. That was the amount that the CDC had spent the year prior on firearm injury prevention research. So this sent a very clear message to the CDC that if you keep investigating in this area, you're going to lose that funding. And when you look at the number of grant awards compared to these rare cases, right, it's pretty significant. Well, if you look at firearms, you can see again the disparity that here exists, right? Well, we recently saw last year, thanks to a lot of incredible advocacy from, so many victims, survivors, groups like Brady, that we finally were able to get Congress to appropriate some funds. They appropriated $25 million, 12.5 to NIH and 12.5 to CDC. Let me just say, this is a great first step, and I don't want to minimize that, but it's also just a first step, and it's actually a very small amount compared to the burden of disease. And of course, you might not be surprised that in fiscal year 2021, in the budget that President Trump just released a couple weeks ago, that $25 million is gone. So we still have a lot of work to do. The public policy approach to this is really difficult, and you heard some of this in the last panel. I think the polarization of this topic is done incorrectly. Adam Winkler talks about this in his book, Gunfight, and he talks about the American culture as it relates to guns. I can tell you that if you look just simply on social media and perhaps even mainstream media, you might think it's that polarized. But I can tell you, as some of you in here have also been doing this work for a long time, if you actually talk to people, and I've done this, and not just in places like Chicago, in places like Kansas and Waco, right, red states, where gun owners will come up to me and they'll say, hey, Joe, we actually agree with the majority of what you're saying. And that's the commonality that Chris was talking about, the commonality that binds us together. But we have to have those conversations. You heard that it's difficult to change, and I think you heard the 60 vote in the Senate, but there's another reason. It's the effectiveness of the gun lobby, and it has to do with money. And Citizens United was a great example, right? As it relates to election spending and the amount that have gone into campaigns, not just directly, indirectly as well, right? And frankly, you know, the problem are not gun owners. I think we should be so clear about that. But when you have an organization like the NRA that is unwilling to move on anything, even something like background checks, you have to ask yourself, well, why is that? And I think that the leadership of the gun lobby, frankly, does not represent the membership. And that's an important distinction, I think, to realize. Even when President Obama was so frustrated at everything that was happening during his term as president, he implemented some executive orders, which if you look at them, these are not things that most of us would disagree with. We're not the first country to have to face this type of tragedy. We saw in '96, the Port Arthur massacre. But the difference is the response into these tragedies. We saw at the time the Prime Minister, John Howard, within 2 weeks implemented a national firearm agreement. Now, I'm not saying that what they implemented necessarily is what's going to work here in the US. But the point is that we have to try something. Doing nothing, I don't think, is an option. We saw that after they had implemented that legislation, there was a decrease in gun homicides by 59% and gun suicides by 65%. Now, I'm not saying this is causation. This is an association. So I'll let you make your own judgments as to whether or not this piece of legislation actually was useful. I don't put this slide up here to make a political statement, but just to say that if you look at what's happening in this country right now, there is a paradigm shift. In 2016, we saw the candidates really starting to talk about this issue, and now gun violence is a central piece of so many of the platforms of the candidates that we've seen over the past year. And I think it just shows us how the tides are changing. And when you look at things like background checks, you can see that over 90%, this is a Fox poll, 90% plus, and the number's closer to 97%. But 90% plus agree with closing those loopholes. I can't think of anything that 90% of Americans agree upon, right? I mean, it's tremendous. I'll just say that, the Bipartisan Background Check Act was, passed over a year ago. And there was a bunch of folks that were involved in this. Yet it still has not been brought up, right, by the Senate. And I'll just point out all the white shirts that you see in the background. We're going to talk about them in a second. As it relates to healthcare, what we have seen is really a profession that was very hesitant to talk about issues like guns really start to raise their voice and have a voice on this issue. And I think Amy Goldberg had published this article that says an apolitical profession wakes up. We are apolitical, but also we have a vested interest in ensuring that we are preventing these injuries from happening. And we've seen healthcare providers involved in this issue on a variety of different levels. Some of you will remember this is our lane that started after the NRA had made the comments that doctors should stay in their lane. And I think what happened with this movement was for the first time, right, the public were able to hear the stories that we were telling and see the pictures, some of which you've seen. And I think we bring a certain amount of credibility to the conversation. And so when we started this, we really didn't know what was going to happen. The first day, it was like 500 followers. And then within a week, it was over 20,000. And I just think it goes back to the point that this, finally resonated with folks, but also it provided an avenue for healthcare providers who for a long time were trying to figure out, how do I have a voice on this issue? It also led to 44 medical organizations across the country coming together here in Chicago to really have the first summit around firearm injury prevention and actionable items that we can implement. It led to things like conversations with presidential candidates. So the point is there's a variety of different ways that you can approach this problem. And not everyone is the same. Some people, they want to be active on social media. Some people want to do research. Some people want to write opinion pieces. And all of those are necessary. So the collective group is what's critical. I'll just leave you with just a couple things. I think one of the things in healthcare that we have for so many years gotten wrong is the fact that we've been so focused on the data. Now, I just want to be clear. I'm not saying this to say that the data does not matter. But data does not change the hearts and minds of people. And it's because of the narrative that I think we've developed, right, that allowed us to resonate with folks. And when I think of one of my professors, Marshall Gans, who is really kind of the world expert around public narrative, he talks about the story of self, the story of us, and the story of now. And I think the point is that whatever your goal is, right, whatever your value is, in order to go from value to action, it's done through emotion. It's done through being able to tell your story. And your story doesn't have to be as dramatic as being shot in the throat, right? Each of you have a story and you have something that you're passionate about. So figuring out how to package up that story and tell it, I think, is critical. Some of you may have seen this Simon Sinek talk, but he talks about the why, the how, and the what. And the point here is that when you look at these really successful companies, right, they're successful not because they tell you how they're going to do something, but they get you to believe in what they believe in. And that's the why. And that's what's so important for us. Finally, you know, all of us have different things that we're passionate about. And this was a great study that followed 10,000 cadets out of West Point. And they looked at external versus internal motivating factors. External being things like, getting paid for their school loans and stuff like that. And internal being, the duty to serve. And you may imagine that those internal factors actually led to success. Now, we all define success differently, but it's something to realize that what we're passionate about is really, I think, what drives us. The young people in this country after Parkland really, I think, re-energized this country and really changed how we're discussing this issue. And I'm just so proud of them, and shame on us for not doing it earlier. When I was in Philadelphia doing my fellowship, I never realized the power of my own story. We used to bring in kids and give them a tour of the trauma center. And then after the tour, I would talk to them about gun violence. And the first time I did this, I hadn't told them my story yet. And I was telling them about gun violence. And they were kind of paying, they're 14, 15-year-olds. So they're kind of paying attention, but not really. And then I told them my story, and all of a sudden, all of their eyeballs focused on me. And I think the point is that for the first time, right, I realized that my story allowed me to relate to these kids that are part of a community where they know someone, maybe even a family member that's been killed, right? These things are happening in their backyard every day. And that was such an important lesson for me. And as much as I love what I do, I know we're out of time here, so I'm skipping along. I'll just leave you with one final thing. The worst part of my job is having to talk to families. Having to walk into those waiting rooms and look at those mothers and those fathers and tell them that their loved one that left that morning is never coming home again. Right? These are not just numbers, right? These aren't just statistics. These are human lives. These are people that form the foundation of our society. And it never gets easier, and it's always something that is resonating in the back of my mind. So I just, say to you, those of you that are not in healthcare, that don't see this on a daily basis, this is a real thing that we're facing. And there's no one solution. We all have to come together as diverse stakeholders to try to implement, I think, a variety of different methods that will help reduce firearm death and injury in America. So thanks to all of you for listening, and thanks so much for having me.
So So thank you to our speakers. So we have time for questions and discussion. I'm sure there will be robust discussion. Maybe I'll start then. I'd actually be interested in the thoughts of all three of the panelists, but any of them. If we focus on the social and economic determinants of this crisis, maybe I'd be interested in your perspectives on what you think are the likely most impactful interventions that can start reducing this. Obviously, it's a complicated situation overall, but I think it would be a good place to start if this is a public health problem, which it clearly is. So I don't know, Selwyn, do you want to start? Okay.
I think I'm going to just jump real fast before I let my boss talk.
Yep.
I think as a trauma surgeon, the very first and easiest thing that we can do is treat our patients with dignity and respect. Because for so long, I think stories have been developed outside of who they are as people, right? They're described as gangbangers or drug dealers, right? And that's not the case, right? So I think the easiest thing for all of us in the healthcare profession is treating everybody with dignity and respect. And then the second thing that we ask all of our patients in conjunction with our violence recovery program is, do you feel safe at home? Right? These are things that anybody can ask. And that anybody can do, and doesn't take money or a big program to implement.
I would, along the lines about the question about economic opportunities, I think Chicago Cred, Creating Real Economic Destiny, is exploring this issue of how much of it is related to economic opportunities, and that certainly starts with education, access, training, vocational training. And if we look more upstream about the social factors that put some people more at risk, especially in impoverished communities on the south and west sides, it's largely around economic opportunities. And if we focus more on investment of our more challenged communities, we can actually have a more lasting impact. Without that long-term view, I think we're going to be dealing with this for decades to come.
Yeah, I'm happy to build on that. So I think we heard Dr. Zackerson in the last panel ask about the structural violence piece. And I think when you're thinking about this problem, again, there's no one solution, but I think you have to look at it as a socio-ecological model. And this is kind of very much typical of the framework as it relates to violence intervention programs. And really there's four, I think, primary components. It's the individual components and looking specifically at what are, doing a risk assessment, what are the risk factors specifically for that individual, education, job opportunities, and so forth. There's also, the second is the relationship piece, meaning the mentorship they have, the peer support they have, the family engagement that they have. The third is the community piece, and the community piece is really, changing the norms of violence, looking at economic opportunities. And then the final piece is a societal piece, and the societal piece is really, policy and advocacy. So there's no one perfect solution, but I think when you look at it, especially from an urban violence perspective, it's really kind of those components that build off of violence intervention programs and so forth.
Good, thank you. Yeah.
Good afternoon. First, I'm a first-year medical student at Pritzker, and so it's very inspiring to hear all of our panelists talk about an issue that I'm very passionate to learn about. My question has to do with a topic that was briefly mentioned in the last panel, and I was wondering about it from the healthcare angle, and that has to do with the police. And I'd imagine they can provide a potentially crucial role in the time between the scene of a shooting and the arrival of a victim at a trauma center. I'm just curious if any of you know whether in the Chicago or the Baltimore context, whether law enforcement are required to learn emergency medical services, and whether there's evidence to whether they have been adhering to those standards or not. Thank you.
Well, the police are often first responders, in terms of providing, CPR on scene should the person have suffered a traumatic arrest. With respect to my prior life in Philadelphia, police officers often were the primary transporters of victims of violence who were traumatically injured, bring them directly to the trauma center, bypassing the EMS system. There's some health systems that do, there's some cities that do that. We don't do that in Chicago.
Yeah, I mean, I can tell you, it's a really interesting question because there's this controversy around, you know, should the police just bring them if they're there? Should they wait for EMS? That's one whole piece that is being discussed. There's papers that are written on it. When I trained in Philadelphia, we saw a combination of both, and I don't think we really, from a data perspective, know what the right answer is. I mean, the bottom line, if someone is bleeding to death, you know, the thing that you want to do is be able to get control of that bleeding. So the quicker that they get to the trauma center and get an intervention, the more likelihood that, you know, your interventions are going to be successful. Specifically as it relates to like what are the types of training that police officers have, I think it's a variety of like, you know, basic training, like things like CPR. I specifically don't know what Baltimore officers are required to have or not have, but that would be an interesting piece to look up.
If I could just answer that question for Chicago. Sorry to interrupt. But this issue here in Chicago has been forth and front and center. When the department recently changed their use of force policies, particularly the policy regarding the use of deadly force, one of the issues that came up with was whether or not they should be required to provide care. And so they wanted to incorporate a duty on the part of officers into the policy. The union pushed back, and probably rightly so, because the officers really had no training at this point. And so this topic is definitely one of the provisions now in the consent decree. So this issue is being dealt with directly by the consent decree in terms of requiring the department to offer officers training and then to incorporate this issue into their policies. Just wanted to
Thank you.
clarify.
Yeah.
So I have a comment and a question. As somebody who grew up in this community, I've seen my share of trauma, including my own visits for sports injuries to the U of C Trauma Center going back almost 50 years. So when it comes to gunshot wounds, I consider the NRA a subversive organization, a terrorist organization. And I would encourage Dr. Joe to use those words as you had put stuff up on the screen. I also want to know, do emergency room doctors and nurses suffer from PTSD?
Yes.
Yes. Yeah, so there's actually a lot of work done around that. There's even a term for it. The term is called second victim. Dr. Albert Wu from the School of Public Health has focused a lot on this, not specifically around you know, just gun violence, but just in general of having to be there and exposed to that, you know, day in and day out. How does that impact the psyche of healthcare workers? And I think it's a real thing, something that not a lot of us talk about. And I'll just say that, you know, when you think about grief, like people have different ways of dealing with grief. You know, some people, they want to talk about it. Some people, they need a bit of time. And it's one of the reasons that after I take care of a trauma patient, especially one that ends up not making it, we'll usually have a debrief with the team to provide the opportunity for people to get it off their chest, to really kind of discuss what went well, what could have maybe been a little bit better. And I find that that's usually helpful.
In addition to post-traumatic stress, I think the other thing that I think we all realize is that sometimes there's a degree of compassion fatigue. You, on an incredibly busy weekend, we can see 20 activations in a day. And if several of those people and families die, it's almost how much do you have in your tank to give? And I think there are times that we're all concerned about what the cumulative effect of that on all of us is.
Yeah, I don't have anything to add. I mean, I think it becomes a defense mechanism, right, to depersonalize our trauma patients. And I think all of us have to actively work against that. Anybody that's taking care of any victim of trauma has to actively work against that. To answer your question, yes, everybody that takes care of trauma patients has PTSD. It's actually actively being studied at our trauma center.
I think we have time for one more question.
Hi, I'm from the western suburbs of Chicago, and my question was regarding how can leaders like the University of Chicago help pioneer a more grassroots organization in fighting gun violence by reaching out to the surrounding communities?
Great question. I mean, some of that is having dialogues like this, getting more disparate and diverse groups in the same room and having a conversation about what the impact is and how we can actually collaboratively work together to make a difference. I think everyone will acknowledge that we want to see less gun violence. The question is, how do we go about doing that?
I'm not from Chicago, obviously. I do love your city, though. And I'll just say, I think you're hitting on something that's very important that we don't talk about enough, which is in order to actually solve this problem, it's not one person or one organization. It requires all of us together. And right now, when you look at our cities, you know, whether it's Chicago or Baltimore, there's so many of our agencies and our governing bodies and our healthcare systems that are siloed off, right? We need to break down those silos, get people to work together, because we heard this earlier about what happens at the local and state level. Most governing happens at the local and state level. And yes, while we want to see change at the federal level, I think engaging groups like the community is so critical. And there's a lot of ways to do that. I'm happy to talk with you offline and if you'd like some thoughts.
Okay, so thank you all very much for being here. I'd like to thank the panel again, not just for the presentations today, but for the incredible work that they do. I think you can see that it's really inspiring to see what they do on a day-to-day basis. It's an incredibly difficult job, but an extraordinarily impactful one. And so we are deeply grateful to the three of you and obviously all of your colleagues for what you're contributing to our communities. Thank you.